Hey everyone, we're going to do a review of Cpap from March EMS training. We're going to go over how it works, indications, contraindications, setup, PEEP, and common errors. Here's the Denver Metro Protocol if you need to pause the video and read this over. Cpap stands for continuous positive airway pressure. Oxygen is forced into the airway at a constant pressure which opens up the alveoli. PEEP stands for positive end expiratory pressure, and it's the pressure in the alveoli above the normal atmospheric pressure at the end of expiration. Cpap maintains PEEP, which results in decreased alveoli collapse, increased alveoli surface area, and therefore improved oxygenation. Here's some pretty interesting statistics. Pre-hospital Cpap decreases the need for intubation in respiratory distress patients by up to 48%. Cpap decreases hospital length of stay by as much as 2/3. Cpap decreases in-hospital mortality by more than 20%. Waiting until arrival at ED to apply Cpap in many studies practically eliminated any benefits. The indications for Cpap are symptomatic patients with moderate to severe respiratory distress, as evidenced by at least two of the following: rales, rhonchi, or wheezes, dyspnea with hypoxia, so SpO2 less than 90% despite additional oxygen, dyspnea with the inability to speak full sentences, respiratory rate greater than 24 despite additional oxygen, and diminished tidal volume. Disease processes that can cause these symptoms include congestive heart failure, failure of the left side of the heart causing a buildup of fluid in the alveoli, COPD, which is chronic bronchitis, inflammation of the lining of the bronchial tubes, emphysema, damage or collapse of the alveoli, asthma, inflammation of the bronchioles, pneumonia, infection causing inflammation and fluid buildup in the bronchioles and alveoli, near drowning, which is fluid in the bronchioles and alveoli, and high altitude pulmonary edema, which is exaggerated hypoxic pulmonary vasoconstriction, and elevated pulmonary artery pressure. Contraindications of Cpap are respiratory or cardiac arrest, systolic BP of less than 90, lack of airway protective reflexes, altered level of consciousness, inability to follow commands or signal distress, vomiting or active GI bleed, suspected pneumo, trauma, patient size or anatomy prevents adequate mask seal. So why is hypotension a contraindication for Cpap? Well, Cpap causes increased pressure in the thorax. That increase in pressure can put pressure on the superior and inferior vena cava, which causes a reduction in blood return to the heart, or reduced preload. A little PEEP review. As we said before, it's the pressure above atmospheric pressure measured in the alveoli at the end of expiration. It reduces the incidence of ventilator-induced lung injury by keeping the alveoli open, thereby preventing mechanical trauma from repeated collapse and reopening. PEEP shifts the fluid in the lungs from the alveoli to the perivascular interstitial spaces, which increases lung surface area available for ventilation. Start at 5 millimeters of mercury. It should come out of the bag that way. If you don't see any improvement, you can increase the PEEP to 7.5 or 10, but keep in mind that you are increasing the interthoracic pressure, so reassess lung sounds frequently and monitor blood pressure. We're first going to watch an incorrect application of the Cpap mask. To start with, the strap has been unthreaded from the white clip, which is going to make tightening the mask a lot more difficult. We don't have a good initial seal as it's over the eyeballs. There we go. Now it's over the face and mouth. But EJ now has to thread that through the white clip, which makes it just more time consuming and harder to get a quick, tight seal. In addition, there's no Capno cannula underneath the Cpap mask. And then the accordion tubing must be 100% extended. We can't leave any extra folds in there. Now we're going to watch correct application. So we're going to start out with the Capno cannula. Colin's going to fully extend the accordion tubing. EJ is going to unclip that white clip. And then this is a two-person job. EJ is going to hold the mask on the patient, or you can have the patient hold the mask if they're more comfortable with that. And then Colin's going to connect the strap to the Cpap via the white clip, and he can further tighten using the Velcro. Once the mask is fully in place, then we can apply the nebulizer. If your patient decompensates, there's no need to rip off the mask, leave it in place, unplug the tubing, connect your BVM, and assist ventilations. Now we're going to review waveform capnography. A little fun fact, the Greeks called the byproduct of the human combustion capnos, meaning smoke. Today we call it metabolism, and the byproduct we know is carbon dioxide. Capnography measures CO2 in the exhaled air, providing accurate and reliable information about airway breathing, circulation, and metabolic status. There are three main capnography technologies used to measure CO2. We use waveform, which is the horizontal axis represents expiration time, and the vertical axis represents millimeters of mercury of CO2. And a capnometer, which we also use, measures the peak end tidal CO2 and respiratory rate. And then the color metric uses litmus paper that changes color when it comes in contact with CO2. Pulse oximetry measures the color of the hemoglobin molecule and then uses an algorithm to estimate the percentage of hemoglobin saturation. As we know, there are a few limitations. The pulse ox cannot decipher what is bound to the hemoglobin molecule, which is important to understand in the case of carbon monoxide poisoning. There are also significant delays from the pulse ox measurement to the finger to the actual ventilatory status of the patient. Low perfusion, cold fingers, fingernail polish, long fingernails, and movement can also impact the accuracy of the SpO2. CO2 is produced after bicarbonate buffers the acidic byproducts of metabolism, and then CO2 is transported by the blood to the lungs, where it diffuses across the membrane and is exhaled. So, during hypoventilation, CO2 builds up in the blood and decreases the pH, causing respiratory acidosis. During hyperventilation, the rate of CO2 elimination is too high, which increases the pH, causing respiratory alkalosis. If hypo or hyperventilation persists for too long, the renal system will have to manipulate the bicarbonate levels in order to maintain a homeostatic pH. All right, so we're quickly going to review the phases of waveform capnography. Phase 1 is the exhalation of dead air that does not reach the alveoli. Dead air fills the upper airway and upper portions of the lower airway and does not contain CO2. Phase 1 ends with the initial detection of CO2. Phase 2 is exhalation. Alveolar air rich in CO2 from gas exchange reaches the upper airway and is detected, causing a sharp rise in the waveform. Phase 3 is continued exhalation. CO2 is being evenly distributed from the alveoli to the upper airway. The slope of phase 3 is very important in determining any delays in exhalation. The end of phase 3 is the highest point and is the peak CO2 concentration, which provides the EtCO2 reading. We use this quite often. And finally, phase 4 is inhalation. The CO2 levels quickly fall to zero as atmospheric air is measured during inhalation, which does not contain enough CO2 to be detected. So now we'll go over some deviations in the Capno reading and what they could possibly mean. So if you see a decrease in EtCO2, it usually means some kind of hyperventilation. So there's a decreased expiratory time, and you'll often see the waveform narrow. So possible causes listed are obviously increased respiratory rate, increase in tidal volume, which will decrease the expiratory time, decrease in metabolic rate, and fall in body temperature. When we have an increase in EtCO2, some possible causes include a decrease in respiratory rate, and you'll see the waveform widen, a decrease in tidal volume, increase in metabolic rate, and rapid rise in body temperature. So the hyperthermia is not related to ventilation. It's that the cell metabolism is increased and therefore the production of CO2. So bronchial constriction. Essentially, it takes longer for the air to be exhaled from the lungs, which causes phase 2 and phase 3 to merge, creating a shark fin. The steeper the slope, the more severe the bronchial constriction. So asthma is COPD. So another cause in the increase in slope of the waveform is partially kinked or occluded artificial airway. So if you have an intubated patient, you have a good waveform and it starts to slope upward, make sure you don't have a kink, make sure it's not displaced. And then obviously the presence of a foreign body will create a triangular looking waveform, and then acute bronchospasms, which we talked about earlier. So rebreathing. While managing a patient who is intubated on CPAP or even on a non-rebreather, CO2 can re-enter the patient's breathing circuit, causing a steady rise in the waveform baseline. It's rare but possible to see, and if you do see it, you probably have a faulty expiratory valve. This can also be caused by insufficient expiratory time. The QR cleft is caused by diaphragm movement in the absence of thoracic muscle movement. We see it when an intubated patient spontaneously begins to breathe on their own. In the hospital setting, they may see it when a muscle relaxant begins to wear off. You may see this waveform if you have an inadequate seal around your ET tube. It means it's leaky or your balloon is deflated. So if you see this, give it a double check. It could also mean that your artificial airway is too small. So CO2 retention and hypercapnia, which is high blood levels of CO2. When a patient retains CO2, a traffic jam ensues in the pulmonary circulation, causing back pressure, which results in high levels of CO2 in the blood and increases in EtCO2 reading. CO2 retaining patients compensate for their condition by having a higher than normal respiratory rate to combat their hypercapnia and hypoxia, and may also retain bicarb to combat metabolic acidosis. CO2 retention is commonly seen in patients with COPD. They have delayed alveolar diffusion rates caused by damaged alveoli and delayed exhalation caused by inflammation and mucus. Asthma, if they have long-term bronchial constriction and corresponding mucus production from inflammation, that results in CO2 retention. We don't always see this in acute attacks. And then generalized ineffective ventilations. Gas exchange is impaired, leading to hypercapnia and high EtCO2 levels. How is Capno related to perfusion and metabolism? Well, if a patient is hypovolemic, experiencing a cardiac event, or has advanced sepsis, metabolic activity decreases, leading to less CO2 production and lower CO2 levels. That's why one of our sepsis criteria is an EtCO2 reading of less than 25. In the case of CHF and pneumonia, there's fluid in the lungs, but not necessarily alveoli damage. So the waveform will be normal in shape because CO2 diffuses through fluid at the same rate as air due to its high solubility. If you see a low Capno, it means that CHF or pneumonia has advanced into either cardiogenic or septic shock. In the case of a pulmonary embolism, there's a clot in the pulmonary circulation, causing decreased pulmonary diffusion and tachypnea, both which can contribute to excessively low EtCO2 readings. The waveform, however, will be normal due to the lack of bronchial constriction. All right, let's do a case study. So you have an 81-year-old male in assisted living complaining of shortness of breath. His history includes CHF, COPD, and decades of smoking. His appearance is pale, moderate respiratory distress, normal mentation, and some peripheral edema, which he deems normal. You listen to lung sounds, and they are diminished in all fields. His vitals are pulse of 120, weak and thready. Blood pressure is 84 over palp. SpO2 is 76 on his normal 2 liters. Respers are 27. His EtCO2 is 38, and his waveform is there to the right. And his 12 lead shows a left bundle branch block. I forgot to put it in the slide, but this guy does not have a fever. Pause the slide here, come up with some differentials and a treatment plan. So some differentials are pulmonary edema caused by CHF, a COPD exacerbation, pneumonia. You could also throw asthma in there. So some treatment considerations. We know that treating this patient aggressively with a continuous ANA neb could possibly worsen the pulmonary edema caused by the left-sided heart failure. We also know that nitro and Cpap are contraindicated due to the hypotension, and we know that nitro and Lasix could potentially not help the COPD exacerbation at all. All right, so let's consider the Capno. So it's a fairly normal waveform, and the EtCO2 levels are typically too low for a COPD exacerbation. If it was COPD, the waveform would have a more obvious shark fin and a higher Capno reading. So that leaves us with CHF pneumonia. CHF commonly presents with a higher blood pressure, which this patient definitely does not have. So that leaves us with pneumonia or cold sepsis because he doesn't have a fever, or cardiogenic shock resulting from CHF. Patient also meets our sepsis criteria despite his normal Capno reading and lack of fever. Pause again. Discuss with your crew. What do you guys think? Follow up on this patient revealed bilateral pneumonia and septic shock. So this guy needs supplemental oxygen and a lot of antibiotics. Definitely don't want to fluid overload this guy with his history of CHF. And Solumedrol could help with pulmonary inflammation in the following days, but it's not necessarily indicated for pneumonia per our protocols. Thank you guys so much for watching and listening to me talk. Get out your Cpaps, get your hands on them if you haven't in a while, and check out your Capno waveforms and think about what those numbers could mean for your patient. Reach out with any questions. Thanks again for watching.